like to thank our sponsors, Genentech, Biogen, and Scholar Rock for supporting MDA's SMA Virtual Learning Series. Hello, my name is Jessica Hubbard, and I am the Manager of Community Education at MDA. We're thrilled to have you join us for today's virtual learning session on treatment considerations, in SMA. The learning event is part of our larger MDA community education program, which focuses on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for updates on upcoming events. We will have a live Q&A session on August 22nd from 4 to 5 p.m. with Dr. Connolly and others from the SMA Virtual Learning Series. I would now like to welcome our speaker, Dr. Connolly, neurologist at Nationwide Children's Hospital in Columbus, Ohio. Thank you so much for being here today. We are so excited to hear about treatment considerations as it relates to SMA. I will hand things over to you, Dr. Connolly.
Thank you very much, Jessica. It is fun to think carefully about SMA. While we've made major advances in the last 20 years, there is still work to be done. I have for this, these are my disclosure slides, and the major one for this is that I have given over the last 5 years, advisory information both to Scholar Rock and Sarepta, as well as Biohaven. Those are the two for SMA that are relevant. I do like to start with the beginning to just show you how far we have come. Really, all of the clinical features for spinal muscular atrophy were described more than 100 years ago. Wernick and Hoffman did this. This is a picture of a 6-year-old circa 1980. And in case you wondered what else was happening there, this picture at that time, this is a picture of a kinetoscope, which is the early introduction of what was moving, a movie camera. You would look in it and the pictures would go by fast and it would give the illusion of movement. But the most critical thing for Wernick and Hoffman was that everything we see is recognized, including the hand tremor, the early death, and the recognition that it came based on not muscle, even though it was called spinal muscular atrophy. It was well recognized that the problem was in the anterior horn cells. So this is a picture of an anterior horn cell with depleted spinal rootlets. And this is the motor neuron. This is what they're supposed to look like. And they recognized very early, in early autopsies, that these motor neurons were not present. I do like to shout out a bit to a couple of the women who contributed greatly to our understanding. In 1960, all of the specific continuum were well recognized. And Betty Banker was a pathologist who had a seminal paper in 1960, just describing exactly why these three look different and why they look different pathologically. And then it was Kuckelberg and Wielander, and I point out that Wielander is Lisa Wielander, few people know that, who recognized this very late childhood or adolescent form where the children seem quite well until presenting somewhere between ages 18 and 15 years of age, and maybe just showing some difficulty running. For many years, including the first 5 years I practiced, the diagnosis was always made with a muscle biopsy. And in spinal muscular atrophy type 1, you can see these are actually at the same power. And these little tiny fibers were really, really, really either completely gone or very, very tiny. Whereas in spinal muscular atrophy type 2, you had some spared fibers. So these fibers are really normal. If I showed you only this slide, this is what you would see. But you can see over on this side of the slide, there are some very small fibers as well. In 1995, and everybody who lived through this time remembers exactly where they were when the gene was identified. It was a very exciting day in science for all of us. And it was a 20 kilodalton gene, so really a pretty small one, and that turns out to be very important. And it encodes for spinal muscular atrophy, encodes for the survival motor neuron gene. So SMN explains SMA. And so whenever somebody's talking about SMN, they're talking about the gene and the protein product. But if they're talking about SMA, they're talking about all of the children. And in this seminal paper, which is, if you want to know a good paper, you kind of see out of curiosity how many times it's been cited in other published work. So 4,551 times. Well, this is your introduction to why it was a little bit difficult to find. We had found many, many other genes before this little tiny gene was found. And that's because there were really two genes, as we now know. There was an SMN2 on the centromeric side of 5q, chromosome 5q, and there's an SMN1, which is on the telomeric side. And this inverted duplication allowed two gene products. SMN1 produces beautiful full-length SMN, but SMN2 produces a single change in exon 7, which tells the gene reading apparatus to not include it. So exon 7 is deleted, and so when you make SMN2, the majority of the product it makes is this defective product which is missing the critical exon 7. So 5q SMN gene, as I said, if you have SMN1, even one copy, you will make 100% of SMN protein. But if you have SMN2 only, you're missing SMN1, then what will happen is, by chance, some of these this little exon mistake, this exon reading mistake, sometimes it's accidentally missed, and that's a good thing. So if it's missed, you'll have some full-length, perfectly formed SMN. But if it's not, you'll have this so-called truncated, and that degrades very quickly and doesn't do anyone's body much good. So Bert Schrank, who was at Washington University and then went back to Germany, was actually the first one, just 2 years after the gene was discovered, to make a knockout. And lo and behold, that mouse did not survive embryonic life. So it was lethal by 104 hours. And we learned subsequently that's because the mouse has no SMN2. It doesn't have that second backup gene, if you will. We now know, and everybody who presents on SMA has some version of this slide, but we know now that how many copies of that backup gene you have is really what's going to dictate how strong an individual is. If you have absolutely no copies of the backup gene or a single copy of SMN2, you have type 0, a single copy, and you will be recognized early in life, usually in the first days of life. But type 1 is associated with 2 backup copies. Type 2, you can see, could be 3 or could be 4. And then type 3 or 3A or 3B, there's a variation in each individual between 3 and 4. And if you have the type 4 where years and years go by before you're recognized, you'll have at least 4 to 8 copies. So now we're going to quickly go to the types of therapy that have worked, and much of this folks know because you've either encountered it or talked about it with your doctor. But the first thing out of the box in 2016 was splicing modification given intrathecally. And then the second thing out of the box was gene replacement therapy. And the third thing was an oral splicing modification. And we'll talk about each of these. Okay. So gene replacement, this is a cartoon from the company and that really does explain how gene transfer works, not only for SMA, but for any gene. And the way this works for SMA is this AAV9 capsule is used. It wasn't chance that they used AAV9 in this case. They knew that AAV9 would deliver the gene to the motor neurons. They knew that from multiple animal model studies. So this was the perfect capsule to deliver the gene. And because this gene is very small, the entire gene was placed inside this capsule and delivered. So what happened, this is it's never unexciting to relive this study done by Dr. Mendel and his colleagues. This study demonstrated that instead of dying within the expected 8 to 9 month range, all children, every child dosed, even those first 3 who were treated with a smaller dose than had been effective, fully effective in the preclinical models, all of them were alive at 20 months. And gene replacement for phase 1, continue to show beautiful efficacy. These slides are also ones that people have seen very early, but I will point out that these first 3 children treated between 5 and 6 months were given the lower dose. But even with the lower dose, there was some modest improvement. 40 is what we would consider on the CHOP and 10, kind of a normal growing child. And you want a child by the age of 10, 15 months, you want them to be up at 60. So these children were not normal, are not normal, but they had some efficacy. And then in the cohort that got the full dose, these are symptomatic. They were known to have 2 copies. In the 24-month study of the second cohort, all of the children past 40, 2 were completely normal. And if you notice how early they were treated, this becomes critical. The earlier the children were treated, the better they did. And there was one child who was treated pretty late, 8 or 9 months of age, and still there was some benefit. This is a happy, publicly released picture of the original children in a sitting position, something that no child with SMA type 1 ever achieved. And this is also a beautiful picture of one of the strongest children who was both able to hang on that and walk. So not only did it show efficacy, it also showed safety. I'm sorry, I thought I had made this a little bigger, but you can take a look at it in your leisure. These are the known side effects from the original phase 1 study, and I'll show you some more safety data here in a second from real world data. Most critically, and people did wonder how long would it last, this is 6-year follow-up of the original cohort, and no child had lost milestones. This is because the motor neuron itself is a very stable. So the motor neurons we are born with are the ones we keep throughout our life. But this was very reassuring to people to know that, not only did safety persist, but some of the children actually continued to gain a few more milestones. I will point out that the two who walked independently remained just those two. But then quickly phase 3 were done. This was to prove that the product could be safely manufactured and delivered. And this was, again, a very exciting trial that demonstrated not only can we do this for a few children, we can do it for more. So before there was SMN replacement, and I put this slide in here, this is kind of the way our life worked. We recognized SMA1 as a bell-shaped curve. Some children were very, very weak very early, some a little bit later. And same for SMA2 and actually same for SMA3. So strength as a continuum, we had these bell-shaped curves. And once we started doing gene replacement, and you'll see this is true for other types of replacements as well, we got this lovely shift. And the shift points out that the severe form of SMA type 1 is really in the United States gone. And the shifting curve, there are still who have, trouble sitting unsupported, but they are at the strongest end of the type 1s. And there are type 2s who are all across the board. The smiley face was chosen intentionally because bulbar function, swallowing, smiling, being able to focus, use your eyes, turn, look at people, interact with the world, was largely preserved. So bulbar functions historically were the last muscles that were lost. And fortunately, even in the children treated later, these were rescued in the vast majority of children with gene replacement. In Ohio, when I first came here with Dr. Waldrop, she led a beautiful collaboration with the entire state. So we followed and tracked every child treated in Ohio and given gene therapy. And we demonstrated very much real world efficacy. It was extremely exciting. These are the same chop and tend. 40 is where you want to be. If you had 3 copies, you were moving, you were passing this up. If you had 3 or 4 copies, you were completely looking like you were tracking completely normal development. And children with 2 copies were improving, but again, depending on when you gave them the treatment. And it was really very safe as well. We tracked very closely liver enzymes because we know that the capsid itself is processed through the liver. That's true for all kinds of capsules, but it's definitely true for the AAV9 capsule for SMA. So GGT was tracked and in all groups. And while there were some peaks treated with steroids during that critical window, all children treated in Ohio safely were treated safely. However, that is not true across the entire real world. Liver failure has been described. Some children have died, and a few children have had thrombotic microangiopathy, which is a risk early on. Many children had dropped their platelet count, and all of that critical monitoring still has to happen every time a child is given gene therapy. Well, splicing modification is also extremely exciting, and I will go through the 2 splicing modifications available. The first is an antisense oligonucleotide, nusinersen. It's given intrathecally. It is something that requires lifelong treatment. The half-life is known. But in this case, what the drug does is to sort of fix that backup copy that's been sitting there all along. And this antisense allows exon 7 to be put back in to the gene. So now you have the beautiful 8 exon SMN protein product. And you have to monitor labs. This was clearly in the FDA guidance before every maintenance dose. And I'll have another word about that in a second from real world data. But nusinersen, there were really 3 beautiful trials done in DEAR, CHERISH, and NURTURE. And the most critical thing about each of those trials is each one taught us something new, which is summarized in the next slide. This is just the diagram of exactly what's involved. Day 1, day 15, day 30, day 60, and then every 6 months. Clearly efficacious. And what I want you to see is that the earlier a child is dosed, the better. So the very best responders, the very best responders were those who were treated pre-symptomatically. And that brings up the same theme that we'll see again and again, that the earlier the better. You'll see that same fact is true for risdiplam. And nusinersen has been extremely safe. Post-lumbar puncture headaches do happen. So there's some nausea, vomiting in a few children, probably related to the headache. Increased intracranial pressure has been described in a few. The concern and the reason for the safety monitoring was that this antisense oligo is processed through the kidneys, and over a long time, might there be renal insufficiency? And the thrombocytopenia could theoretically happen. But in this really beautiful collaboration of all of the children dosed at Washington University in St. Louis and published by Natalie Godecker, 45 children, 494 doses, all of them with safety labs obtained. Extraordinarily safe. There was never a laboratory study that for which we said, oh, we better not give the dose. So more to follow on this, but this is pretty nice data over 3 years. So how about the oral splicing modification? We know this is risdiplam, and it is also, of course, FDA approved. If you're over 20 kilograms, it's a fixed dose of 5 milligrams. It's given as a liquid. They're working apparently on a pill form that will be good, but there's a lifelong treatment again required, but no laboratory monitoring. The mechanism of action is similar but not identical. Again, we're working on SMN2 to make it more functional. Initially, it was only approved at the 2-month level, which meant that you would have to wait 2 months to give it for any newborn diagnosed. But subsequently, safety data emerged and the FDA expanded the label, so it can now be given at less than 2 months. Very efficacious. And here again, I want to point out that the earlier, the better. SMA type 1 with 2 copies. This was a dose escalation, and they had, again, 12 patients. This is in the early symptomatic. These children were already weak, had already lost some motor function. Really exciting when this paper came out that swallow was maintained. But 3 infants did die of causes related to the known comorbidities of SMA type 1, which is predominantly respiratory. Again, very safe. The major side effects that we disclose to all patients is some abdominal discomfort in some children. Stools can be a little bit looser. Some children developed a cough. Some children complained of palpitations or muscle twitching. Those have not persisted to a significant degree in children treated in the real world, but they were definitely noted in the first trials. So which therapy is best? It's very interesting, this paper, and I would put it out there. I don't usually just grab a whole article, but the reason I put it out there is really the only clear comparisons that have been done. No trial has done this. No company has said, oh, I'll put mine against yours, we'll do it the same. But it does turn out that for spinal muscular, for risdiplam and nusinersen, the entrance criteria were very similar for those two studies. And so when people looked retrospectively at those, the difference was that with risdiplam, bulbar function was a bit better preserved. So the conclusion from this work is that for very, very early on, maybe risdiplam wins, but really a trial hasn't been done. And there are some children who are treated pre-symptomatically with nusinersen who also did phenomenally well. And the other driving home point, I could talk for an entire half hour about newborn screening, but we do know it helps with outcomes. The earlier, the better. So this is risdiplam data, and they demonstrated that in this group, all of these children were identified by newborn screening. And so look how early the risdiplam was started. And this work, whether it was infusion or nusinersen, whatever they did, the earlier the better. So how about risdiplam versus nusinersen in older individuals? There really are not very many studies. It's very difficult to find treatment naive individuals. And so moving forward, we're going to have to rely on real world data. If somebody switches, what time did they switch? Is it at a time when SMA is known to be relatively stable? So we really don't know. Lots of people are switching one way or the other for different reasons. The other complication for these older individuals is that the disease itself often has taken its toll. The effect on the breathing muscles themselves varies, so pulmonary function is very different. So the starting points for risdiplam, I really don't think we can fully say. But what is clear is that now in this world, we have new SMA phenotypes. We have those who are pre-symptomatic or minimally symptomatic, and newborn screen identified them and they're doing well. It is definitely true for 3 and 4 copy infants who are treated in the first weeks of life. Those children are doing extremely well. So we give them a green. Now for yellow, and sorry if your eyes don't pick it up very much, how about those who are newborn screen and did identify them? They're doing well, but their developmental gains are slightly slower. Like no matter which treatment they are given, you can go to all of the previous papers and there's always this group. And it's a subset of the 2 copy infants. And it could be as many as 50% of them that when you treat them as early as you can, but for whatever reason, they have already lost some motor neuron function. And that's a subset that we are seeing revealed in the United States. And finally, unfortunately, there is a clear symptomatic group. We know that newborn screening is only going to identify 95%. The reason for that is newborn screening does not, if you have one mutation that is a deletion, and you have another mutation that is a point mutation, those children will not be picked up by newborn screening. And so those are going to be missed. Also, newborn screening relies on humans, and humans make mistakes. It's there are lots of checks and balances, but no newborn screening program is perfect. There are a very sizable subset who were born prior to newborn screening. Different states enacted newborn screening at different times, and so there's quite a large cohort of children and adults with SMA who were just born before newborn screening and didn't have access to the three major treatments I talked about. And finally, any child born in any other country in the world, unfortunately, most countries, especially resource-limited countries, do not have newborn screening in place. So I go back to this little curve. I want you to remember the curve is shifting. It's shifting for USA. It's shifting in other resource rich countries. This is shifting. It's shifting for children whose families may have had a child already and therefore do the next child, even if newborn screening is formally in part in their country. So this is true, but unfortunately, this is also true. There's just countless thousands and thousands of children for whom that bell-shaped curve has not shifted. Currently underway, there are 2 trials. I don't have time to go in detail about them, but the next update will certainly be true. Both of these are myostatin inhibition trials. They both use monoclonal antibodies, and these antibodies are either delivered intravenously in the case of the Scholar Rock product or subcutaneously in the case of Biohaven. Biohaven's phase 3 is complete, and I think we will be getting additional data from that soon. So in conclusion, treatment as early as possible will be most successful. Treatment later with any of the SMN2 modifying treatments does have benefit, but the amount of benefit will vary depending on how much strength they had to start with. And then combination therapy may be beneficial. We will find out across the next few years. I do have an SMA dream. My SMA dream is that there will be worldwide newborn screening. There are about 200,000 babies born every day. And mathematically, that means this equal opportunity disease will land in 20 children every single day. The math in the state of Ohio is that we have about 74,000 per year, and between 12 and 16 of those are born. So I dream of universal access to treatment, and I dream that no child will die from SMA type 1. I have many people to thank here at Nationwide Children's, and I probably left some off the list, but I'm deeply grateful to all of them. A special shout out to Megan Waldrop, Dr. Albert Sau, Elaine Meyer, and Shannon Chagat, who really do walk the walk. All of our physical therapists are spectacular, and a special shout out to Dr. Jerry Mendel, whose vision really guided that first-in-human gene transfer for SMA. Finally, and perhaps more, and definitely most importantly, the many children and adults who have allowed me to care for them across more than 3 decades. Thanks very much. And of course, the state bird for all of you is the cardinal.
Thank you so much, Dr. Connolly, for sharing this valuable information with our MDA community. We look forward to hearing from you again at the SMA Q&A session on August 22nd at 4 o'clock Eastern. And this concludes our virtual learning session on treatment considerations for SMA. We would like to thank our sponsors, Genentech, Biogen, and Scholar Rock for supporting MDA's SMA virtual learning series.